So we'll start the class. Is it
Yes,
visible?
sir.
Yeah.
Sir, it is visible, sir.
Now is it written mitral valve disease?
Yes, sir.
Mitral regurgitation?
Yes, sir.
Okay. Yeah. So we'll start today's class. So last week we were studying regarding mitral regurgitation. So today what we will do is we'll go into mitral stenosis. So last week when I was telling to you about valvular heart disease, I was telling you the basic hemodynamics is important to understand the murmurs. So while I taught you about mitral regurgitation, I taught you that there is a systolic murmur and the systolic murmur is pan-systolic murmur. The reason what I was telling you is that it's systolic because regurgitation is a disease which affects closing. It is improperly or incompletely closed. And mitral valve is closed, should be closed during left ventricular systole. So mitral regurgitation murmur will be systolic murmur. And it is pan-systolic because I told you left ventricular pressure is around 80 to 120 and left atrial pressure is around less than 20. So the gradient is very high. So from the beginning of the systole till the end of the systole, you will have regurgitation of blood from the left ventricles to the left atrium. So the murmur will be audible from the beginning of the left ventricular systole till the left ventricular systole till the end of left ventricular systole, and so you will get a pan-systolic murmur. And I told you about the other clinical features also. So today we will be running through mitral stenosis. Since already you are thorough with mitral regurgitation, mitral stenosis will be quite easy for you. So I covered these things. So mitral stenosis. So the causes of mitral stenosis per se, it can be many things. Like I told you about mitral regurgitation, it can be a rheumatic heart disease. So in rheumatic heart disease, in acute state, in acute rheumatic heart disease, you might not have a mitral stenosis. But if the rheumatic heart disease is going to progress, the fibrotic stages will progress for the patient. And due to fibrosis, the patient will have stenosis of the mitral valve. Then you have mitral valve annulus calcification, drugs like midostaurin, then amyloidosis, you can have mitral valve stenosis, SLA. In SLA, I told you, you can have both mitral valve regurgitation as well as stenosis. Rheumatoid arthritis also, you can have both stenosis as well as regurgitation. Carcinoid syndromes, you can have mitral valve stenosis because of the pro-inflammatory carcinoid particles like serotonin. It will cause stenosis or contractures or fibrosis of the mitral valve. Hunter syndrome, Hurler syndrome, infective endocarditis with large vegetations. I told you, usually infective endocarditis causes a mitral regurgitation because the chorda tendae is going to break out, or there is going to be a vegetation which is going to sit in between the annulus and the valve leaflet, and it will cause a regurgitation. But if it is a large vegetation, it is going to occlude the mitral valve outflow. So it can cause a mitral stenosis also. Types of mitral stenosis, it is very important. It can be supravalvular, that means anything above the valve. That means it will be around the left atrium. Or valvular, the pathology is in the valve leaflet. Or subvalvular, behind, downward. So supravalvular can be fibrous ring here, or Sean syndrome, that is the congenital syndrome. Then valvular, you have fusion of the commissures, the valve commissures, they got fused. Or you have annular hypoplasia can be there. This annulus will be very small. That is known as hypoplastic left heart syndrome. Then subvalvular, you have single papillary muscle or parachute valve, that is known as parachute valve. Usually we should have two papillary muscles, anterior and posterior. So single papillary muscle means it is parachute valve that can cause a subvalve. When it is single papillary muscle, from single papillary muscle, chordae tendae will rise from here. For example, if this is a single papillary muscle, from here both chordae tendae is going to come. So what happened? It will cause a constriction like this. Like if you have two rubber bands connected like this, it will cause a contracture like this and cause a mitral valve stenosis. Then abnormalities like in the papillary muscles, you can have abnormalities that is known as hammock valve or absent papillary muscles. When the papillary muscles are absent congenitally, there can be, what to say, the caudate tendon get compressed like this, and the valve outlet get compressed like this, and you can cause a mitral stenosis. So, what are the clinical, pathological, or pathophysiological feature you have to understand about mitral stenosis is, like I taught you mitral regurgitation, the clinical pathological progression for mitral stenosis is also very important. What happens when you have a mitral stenosis? The left atrial pressure is going to slowly increase. So I told you about mitral regurgitation. In mitral regurgitation, I told you last week, the left atrial pressure increases very slow. But in mitral stenosis, the left atrial pressure will increase more rapidly than that of mitral regurgitation. So in mitral stenosis, since the blood is not emptying into the left ventricles, since the left atrium is not emptying fully into the left ventricles, the left atrium is going to expand and the left atrial pressure is going to increase. So left atrial pressure, when it increases, it goes into the pulmonary circulation. So the pulmonary congestion happens and there will be pulmonary artery hypertension and dyspnea will be there. So in a case of mitral stenosis, dyspnea can be earliest manifestation of the patient. So whenever the pressure increases in the pulmonary vessels, there will be pulmonary or bronchial vessel rupture and the patient can come to you with hemoptysis. Again, what happens? The back pressure to the lungs increases and the patient can predispose into systemic congestion as well as pulmonary congestion, and pulmonary edema and systemic hypertension can happen to the patient. Again, I told you the left atrium is going to dilate. If the left atrium dilates so much, the pulmonary artery hypertension comes, left ventricle, the back pressure comes to the right ventricle. Sorry, the back pressure from the, when the lungs get congested, again from the lungs, the back pressure will come to the right ventricles, right atrium. So right ventricular dilatation happens in the later stages. So in mitral stenosis, dyspnea is going to be one of your earliest manifestation when compared to your mitral regurgitation. In mitral regurgitation, I told you increased fatigability or early fatigability was your earliest manifestation. But in mitral stenosis, dyspnea is going to be your earliest manifestation. So comparing, last week I taught you about mitral regurgitation. Comparing between mitral regurgitation and mitral stenosis, I am telling you, mitral stenosis, you have dyspnea as the earliest symptoms, while in case of mitral regurgitation, you have fatigue and due to decreased cardiac output as the earliest manifestation. Hemoptysis, I told you, in mitral stenosis is common. Pulmonary artery hypertension is common in mitral stenosis. While in mitral regurgitation, I told you the hemoptysis occurs only in acute MR. That is, if you're going to have a very acute sudden MR, even that happens only in case of caudate tendon ruptures, like in case of post-coronary artery disease, post-ACS mitral regurgitation, acute MR happens. Only in that case you will have hemoptysis. Otherwise, hemoptysis is rare in case of mitral regurgitation. And pulmonary artery hypertension happens in mitral regurgitation only during the late stage. While in mitral stenosis, pulmonary artery hypertension, hemoptysis, dyspnea is very common. And pulse, about the pulse volume of mitral stenosis, that is very important. It is low pulse volume or small pulse volume. The reason is, I told you, the mid atrium is not able to empty into the left ventricles completely because the mitral valve is stenosed. Since the atrium cannot empty into the left ventricles completely, the amount of blood that is going to come out from your left ventricles into your aorta, into your systemic circulation will be less. So the pulse volume will be less in case of mitral stenosis. While in mitral regurgitation, there will be wide pulse pressure and better pulse during the earlier stages. Why? I told you while I was teaching you about mitral regurgitation, I told you in mitral regurgitation, there will be Frank-Starling law applied. Due to Frank-Starling law, the blood which was regurgitated back, it will come down and it will cause dilatation of the left ventricles, and within the physiological limit, it will cause an increased contraction. So the blood will pump out. So in the early stages, there is a increase in pulse pressure and there is wide pulse pressure. The pulse pressure is wide because of what? Diastolic component of the pressure will be widened because of the regurgitation, and the systolic component will be increased due to the increased contraction. Apex beat. About apex beat, when I taught you about mitral regurgitation, I told you since the left ventricles is going to dilate, you will have an shifted outward, downward, wide apex beat in case of mitral regurgitation. Hyperdynamic also. But in case of mitral stenosis, the apex beat will be in the same position only. It is not going to shift down. The reason is you do not have enough amount of blood in your left ventricles to dilate the left ventricles. So in mitral stenosis, the left ventricle apex beat is going to be in the same position, and the character will be a tapping apex beat. It is tapping because in mitral stenosis, the S1, what is S1? S1 is the closure of the mitral valve. The mitral valve is going to close early and very forcefully and very quick against a pressurized or against a raised pressure left atrium. So when the S1 or when the left atrioventricular valve, mitral valve is closing, that sound gets transmitted as a tapping apex beat. Second thing, the apex beat, the heart is going to pump, come, knock you, and go away. What happens is in mitral stenosis is that left ventricles doesn't have enough amount of blood. So what happens is the left ventricle, while it is contracting, it comes very quickly, hits in your hand, goes back, hits in your back, hand, and goes back, hits in your hand, goes back. So these two reasons you will get a tapping apex beat. One reason is the S1, you will the palpable S1 will give you an impression of tapping apex beat. Second reason is the apex very quickly, due to the left ventricular easy contraction of the left ventricle, the left ventricle will easily come, hit in your hands, go back, hit, go back. Other thing is left parasternal heave. In mitral stenosis, I told you in later stages, the parasternal heave can happen due to raised pulmonary artery hypertension, and that will reflect into your right heart, and you will have a right ventricular hypertrophy, right ventricular heave. So you will get a left parasternal heave due to right ventricular hypertrophy. While in case of mitral regurgitation, parasternal heave is less likely, and what you can get is sometimes you can get a parasternal lift, and that parasternal lift which happens in mitral regurgitation is not always due to right ventricular hypertrophy, but it is due to left ventricular hypertrophy. And mitral stenosis, P2, what is P2? Palpable component of P2, that is we have A2 and P2. P2 in mitral stenosis will be palpable. Why? The reason is in mitral stenosis, I told you, there will be pulmonary artery hypertension in mitral stenosis. And so you will get a palpable P2 in mitral stenosis. In mitral regurgitation, I told you pulmonary artery hypertension is rare or late. So in mitral regurgitation, you are not going to expect a palpable P2. And about heart sounds. In mitral stenosis, you will have a loud heart sound, or your S1 will be loud because your mitral valve is going to close against a pressurized left atrium. So there will be a loud sound which is hearing, like your left atrium is going to it's going to suck your mitral valve. So due to the pressurized left atrium and due to the suction effect, you will hear a loud S1. But this is a point which you should remember. In calcified MS, or whenever you have an MS with MR, your S1 will be soft. While MR, while I was teaching it, I told you in MR, S1 is soft only. And about S2, what is S2? S2 is due to the closure of aortic valve and pulmonary valve. I told you in S2, in mitral stenosis, I told you there is pulmonary artery hypertension. Whenever there is a pulmonary artery hypertension, I told you the pulmonary valve is going to close late. And the A2 aortic valve, it will close early in case of mitral stenosis because blood will be inadequately available. So naturally, there will be a widening or split in S2, mainly due to delayed P2 due to pulmonary artery hypertension. And the P2 will be loud also, like you can have a palpable P2. MR, why I told you, MR also S2 is going to split. The split of S2 in MR is mainly due to early closure of A2 due to early emptying of left ventricles. I told you some amount of blood will go back into the left atrium. So the amount of blood emptying from the left ventricles in mitral regurgitation will be less. So A2 will close early. And about S3, last week when I told you S3 is due to increased ventricular filling. In MS, since there is a mitral stenosis, blood is not going to come from your left atrium to your left ventricle. So S3 cannot be expected in a case of mitral stenosis. While in case of mitral regurgitation, I told you all the blood which got regurgitated during the diastolic phase, it will come down and there will be increased left ventricular filling, and so there will be a left ventricular S3 heard in case of mitral regurgitation. S4, S4, I told you, it is due to rapid filling of the atrium and vibration of the stiff ventricles. So in mitral stenosis, what happens? There is no blood to the due to the stenosis, blood is not going to fill rapidly, or it's not going to rapidly contract your atrium and fill your left ventricles. So you will not hear an S4 in case of mitral stenosis. But in mitral regurgitation, S4 can be heard. And whenever the left ventricular failure happens, S4, I told you, it will be surely heard in late MR. Opening snap. Opening snap is heard in case of mitral stenosis. Usually, I told you, whenever the valve opens, there is no sound. And when the valve closes, you can hear S1 and S2. So in mitral stenosis, since the valve is calcified, you are going to get an opening snap since the valve is stenosed, not calcified. Since the valve is stenosed, you will get an opening snap in case of mitral stenosis. So murmur. About mitral regurgitation, while I was teaching you, I told you that the murmur of mitral regurgitation is a pan-systolic murmur. Reason also I told you. In mitral stenosis, the murmur is going to be a diastolic murmur. Why? This is something which you should hear and understand. What is stenosis? Stenosis is inability to open properly. When should the mitral valve open properly? Mitral valve should be opened during the diastole of left ventricles. So the murmur of mitral stenosis is going to be during which phase? It is going to be a diastolic murmur. And why is it mid-diastolic murmur? The reason is very obvious. I told you, the left atrium is going to fill the left ventricles during the diastolic phase. So the pressure difference, where is high pressure? The high pressure is in your left ventricles. It is your diastolic pressure of your left ventricles is going to be 70 to 80. While your pressure in your left atrium, maximum it is going to be 15 to 20. So the pressure difference is the pressure in the left atrium is less than that of left ventricles. So during the diastole, during the initial phase, with the normal physics, we do not expect blood to quickly come down from the left atrium to left ventricles. The amount of blood which will be coming down from the left atrium to the left ventricles will be maximum only during the mid phase, because the blood should slowly come down. Contraction of the left atrium should happen only during the mid phase. Maximum blood will come down. Only at that time you will hear a murmur. That is why you have a mid diastolic murmur. What is pre-systolic attenuation? Pre-systolic attenuation, because you know the ventricular filling is of two types. One is passive filling. Second one is contraction due to the atrial contraction. Pre-systolic attenuation happens because just before the systole of the left ventricle, there will be a forceful contraction of the left atrium. At that time, you can have a increase in your murmur intensity. And the site of murmur is apex. Radiation in mitral stenosis, the murmur is not going to radiate anywhere, because the blood coming from the left atrium to the left ventricles is very less. So it is not going to radiate anywhere. The sound wave is not going to radiate anywhere because you have a stenosis there. Pitch. Mitral stenosis murmur will be a low pitch sound. So all low pitch sounds can be heard best using your stethoscope bell. The reason is, if you use a diaphragm, the diaphragm will automatically cancel your low pitch sounds. So if you use a diaphragm, the mitral stenosis murmur might not be heard. So always use a bell which will not cancel your low pitch sounds. So with that, you can appreciate your mitral stenosis murmur. Secondary murmur in mitral stenosis is heard in the pulmonary area due to pulmonary artery hypertension, not due to any other cause. And maneuvers which increases the murmur in mitral stenosis is expiration will increase the murmur, and it is decreased by exercise or activities. I told you AF is common in case of mitral stenosis. Why? Because your left atrium is going to dilate and it will cause AF in case of mitral stenosis. While in mitral regurgitation, I told you AF is less common. So this is what I told you about mitral stenosis. This is very important about mitral stenosis. This is S2 opening snap gap. So you have your S2 in severe MS, the left atrial pressure will be very high. So when in severe MS, when the left atrial pressure is very high, the mitral valve, it will open very fast. It will open early. So what happens? The opening snap will be early. So the gap between the S2 and the opening snap, S2 is, closure of the pulmonary valve, and S1 is closure of the atrioventricular valve, mitral valve. So the opening snap, the gap between S2 and the opening snap will be reduced whenever you have a severe MS. The reason is when there is a severe MS, the left atrial pressure will be high and the mitral valve will be opened early, and so opening snap will be heard early. So the gap between S2 and opening snap will be reduced in case of severe MS. This is what I have drawn. S2 opening snap will be reduced in case of severe MS. And this is the murmur which I told you. It will be a mid diastolic murmur with a pre-systolic attenuation. The gap between S2 and S1 is the diastole. Duration of the murmur also signifies the severity of mitral stenosis. And atrial fibrillation, if present, that is suggestive of a severe mitral stenosis. S2 opening snap, duration of murmur, and atrial fibrillation, they are suggestive of severe mitral stenosis. So class, this is about mitral regurgitation I told you. ECG finding of mitral stenosis. Since the left atrium dilates, left atrial enlargement is there, you have a P mitrale. And in severe MS, you have a right ventricular hypertrophy. And in ECG, you can see changes of right ventricular hypertrophy. That is R wave in V1 will be more than 7 mm. And if there is AF, you can see irregular rhythm with absent P wave in ECG of AF of MS. ECG of MR, I told you. X-ray of MS, the same changes, dynamic changes. You have left atrial dilatation, spraying of carina due to left atrial dilatation, straightening of left heart borders, curly A lines, curly B lines. They are due to pulmonary edema. This is your X-ray showing you what dilatation of the left atrium, prominent left atrial dilatation, and you have splaying of the carina. This carina is being splayed due to widening of the left atrium, and see even the right atrium has been enlarged. So this is a typical X-ray of a rheumatic heart disease, and you have your prosthetic valve of mitral valve shown here. This is curly A lines and curly B lines. This is a curly B lines which are early seen, and this is a curly A lines. Curly B lines are short septal lines, and curly A lines are lines extending from the hilum. This is the curly A lines, and this is a curly B lines in pulmonary edema. Echocardiography of mitral stenosis, you can see thickening of the valve, immobile valves, and increased diastolic filling can be seen, and reduced valve area. So normal valve area is 4 to 6 centimeters square. In severe MS, it will be less than 1.5 centimeter square. Treatment of MS, it is very important. Like MR, it is again depending upon your clinical features. If you are having NYHA 3 or 4, and you are having severe MS, that is valve area is less than 1.5 centimeters square, you should do and the valve is pliable. If the valve is pliable for repair, you should do a percutaneous mitral valve balloon commissurotomy. What does that mean? If a valve is pliable for repair in a mitral stenosis, and if you are symptomatic and severe MS is there, through the arterial line, through your arterial line, take a catheter into your left atrium, and you keep a balloon there and dilate the stenosed valve. That is known as percutaneous mitral valve balloon commissurotomy. If the valve is not pliable, in that case, you should do a mitral valve repair or surgical commissurotomy. You cannot do percutaneous procedure. In severe MS, but your NYHA is 1 or 2, just observe the patient. In calcified mitral valve, you cannot do a percutaneous mitral valve commissurotomy because your balloon will break. You cannot expand using your balloon. So you will have to take a comprehensive decision. Should you do a surgery or observe the patient? So maximum possible, if calcified valve, we will observe the patient conservatively. And whenever the patient is symptomatic only, we will go ahead with a surgical repair. This is the criteria for doing a percutaneous balloon valve commissurotomy. That is isolated MS, no calcification, there should not be thrombus, and the valve should be pliable. MR I told you. So this ends your class regarding mitral stenosis. So read back and get back to me if you have any doubts. I never wanted to take an online class today because this is not a class supposed to be online, but your rep wanted me to. So next class, if it is offline, we will learn about other valvular heart disease. Thank you. God bless you. Thank you.
Thank you, sir.